Hello, everyone, and welcome to today's webinar, Navigating the New CMS Attestation Requirements, Identifying and Addressing Potential Pitfalls. And thank you all for joining us. I'm Dr. Mark Smith. I'm the Chief Medical Officer at the Hardenbergh Group, and I'll be moderating today's program. Today's webinar is being sponsored and hosted by the Hardenbergh Group. Before we begin today's programs, I'd like to share a few housekeeping details. All attendees' microphones have been muted for the presentation and chat has been disabled. To ask the presenters a question, click on the Q&A icon located in the navigation bar at the bottom of your screen and type your question. As time permits, at the end of the program, I will read the submitted questions and ask our presenters to respond. And if there's any extra questions, we will get answers to you afterwards. We're required to inform you that we have no disclosures for today's presentation. Continuing education credits will be emailed to you within 24 hours directly from Hardenbergh in your thank you for attending follow-up email. Also included in the email will be the slides from today's presentation and a link to a short survey, and we'll hope you'll take a few minutes to share your feedback. We're very excited to tell you about our upcoming Senior Medical Staff Leader Forum taking place in April in Denver. The forum is a two-day event designed for senior medical staff leaders and will feature presentations by 10 highly experienced physician leaders from across the country. The forum is focused on providing a collaborative exchange of ideas and networking opportunities for leaders who are too often isolated from others sharing similar administrative roles. We hope you'll be able to tell your medical staff leadership about this event, as space is very limited. You can visit the Hardenbergh website to get more information and to register. And we're certainly open to anyone with questions. And with that, I'm going to introduce today's panel that we've assembled to talk on these questions and issues. First, we have Maggie Palmer, who's the Vice President, Medical Affairs at Parkland Health and Hospital System. Welcome, Maggie. Next, we have Michael Callahan, Senior Consultant with the Hardenbergh Group. Welcome, Michael.
Good morning, good afternoon, everybody.
And finally, but certainly not least, we have Dr. Brock Bordelon, who's the Medical Director of Surgical Services at the Hardenbergh Group. Welcome,
Thanks, Mark.
Brock.
Appreciate it.
So, on October 1st of last year, with very little fanfare, CMS instituted new rules attached to the Patient Safety Structural Measures, or PSSM rules. And these mandates fall into 5 domains and are scored with the intention of requiring 100% compliance with each domain to get credit. And in fact, organizations will have financial consequences tied to the performance here. For all these reasons, we think these are important issues to pay attention to. The rationale CMS has given for these changes is to promote a greater proactive approach to patient safety by establishing a stronger infrastructure within institutions that will help to accelerate the prevention of harm rather than addressing harm after it occurs. We feel it's important for all hospital organizations and everyone in them to expeditiously understand and execute compliance in these areas, and hence the real push to do this presentation today. We've put this panel of experts together to provide you with the necessary information that you will need. And so with that short introduction, I'm going to turn it over to Dr. Bordelon.
Thanks, Mark. I think this is an enormously broad topic that has gotten very little attention. And what we're trying to provide today is a primer, really an introduction to what the patient safety structural measure means, what it represents, and really where the pitfalls are for you as an institution, as a facility, and where actually the gains may be for patient safety. So we're gonna introduce you to each of the domains. We're going to give it a sampling of the implementation guidelines with the attestations that are required. And we're going to do this with a focus from an attorney's perspective, medical staff service perspective, and a physician perspective, because each of these different aspects of the PSSM really have to be put into motion to be successful. There's an awful lot here, but there's an awful lot here that you should already be doing. So take a deep breath, don't panic with all this information. Just remember that you need to ensure that you're meeting these measures that you are organized, and that you're documenting things very, very well. Why are we here? Really, this came about after quite a bit of discussion and a lot of input from a lot of folks about the prospective payment system final rule that came out last fall. But it was done very quietly. Who does it apply to? And basically, every hospital that's participating in the CMS's hospital inpatient quality reporting program, as well as the PPS exempt cancer hospital quality reporting programs. There's 5 separate domains, and each of those domains contains very specific components. We're all familiar with how CMS gives vague guidelines. This is a very different structure. There's very specific information that's being provided and very specific directions that's being provided to hospitals. Each of those domains includes attestation statements that are required to be signed by your hospital board members, with a total of 25 of them, and we'll go through some of those and explain what they mean. Extensive input was solicited from a variety of partners, and I would say probably calling out the Institute for Healthcare Improvement as being one of the most important of those providing significant input. And the reason is a lot of attention has been paid over the past several years to improving quality and patient safety, but we haven't moved the needle very much. So the goal is to try to shift our quality reporting from outcome metrics, wound infection rates, and surgical complications, to really changing the organizational structures and policies that focus on patient safety. So what are the 5 domains? Basically, it involves a commitment from the hospital leadership entirely, including the hospital board, strategic planning and organizational policy changes, developing a safety culture and a system that provides a learning environment. There has to be accountability for safety, as well as transparency in how we're doing reporting. And there's a requirement for patient and family engagement, and that's really very crucial. The process starts now. Hospital reporting and attestation starts in 2025. The information is going to be published by CMS in 2026, and in 2027, there's going to be some reimbursement cuts for those that are not reporting. How that's going to happen and how that reporting occurs is still being worked out, but just know that within 2 years, there's going to be some financial penalties for folks that aren't actually meeting these measures. So I'm going to turn this over to Michael at this point to start describing how these domains work.
Thanks, Brock, and thanks everybody for joining us today. The sequence we're going to go through is I'm going to start off with an overview of each of the domains and some of the attestation requirements, followed by Maggie, who then is going to talk about what impact each of these domains have on MSPs and other registrants to this particular program. So we're going to go through this pretty quickly. So hang on to your belts or whatever as we move forward. And also, strong suggestion that once you get these slides, to please pass them on to other members within your organization, because this affects everyone at the hospital and throughout the entire healthcare system. So the first domain is leader commitment to eliminating preventable harm. As Brock said, the reality is, despite the passage of all sorts of laws and accreditation standards, et cetera, there's still a lot of medical errors being performed, prescription errors being performed. Health of patients haven't improved nearly as what has been expected, and if not required. And so these domains, as well as federal law and state laws, place a lot of responsibility on the governing board of hospitals. And as you know, physicians also serve on these governing boards. And even though there are quality plans, QAPI plans, and most hospitals have some kind of policy, the real question is it just paying lip service, or are they actually taking steps, proactive steps, to not just adopt policies, but to audit policies and to oversee them, to check out outcomes, and to continue to move the needle in improving patient care? So patient safety clearly is central to all strategic, financial, and operational decisions that are made by the board and have to be documented as such. Some of the attestations that are going to be expected, and again, right now it's just attestations. Each of the hospitals have to attest that they're in compliance with each of these 5 domains. But at some point, it's going to be, the rubber is going to hit the road. There's going to be auditing for compliance. How that's going to shape up, it's hard to tell. but you get 1 point for satisfying each of these domains. And by the way, that's going to be made public. You will know if your hospital is or is not meeting all 5 domains. And if not, that's going to be a reimbursement implication, could be a marketing implication, et cetera. There's a great self-assessment tool that you note in the lower left-hand corner. This is part of the process in terms of where do you stand on promoting and actually effectuating improvements in safety. So please take a look at that. It's a wonderful tool. There are other tools that are out there, and you may already be doing some self-assessments. But I think what we have found is that, really following up on this is somewhat spotty at best, and most hospitals need to take that additional step. So I'll turn this over to Maggie for her input now.
Thank you, Michael. So when I first was asked to be part of this panel, of course, I had to do a little bit of research, and so I didn't feel overwhelmed. But as I go through this, you'll see a lot of the stuff we're already doing organically. So, just like we said, buckle up, but hopefully there's a lot of items that you're already doing. And I also want to acknowledge every organization is different. You might have a medical staff professional that does everything, even manages at the board meetings, or you may have some that never go to the board meeting. So there's other things. You don't want to exclude yourself at any path along the way, but I think it's really important to be knowledgeable in these areas. So one of the things is that you want to have a dedicated time on agendas. And we start that dedicated time on agendas, of course, to our peer review oversight committee, which goes to our medical executive committee, and that goes to our board. And we see the dedicated time on agendas, and we'll talk a little bit more about what that dedication time looks like. And then templates for minutes, ensure accurate reflection of discussions and data presented. As you know, they're called minutes and not hours, but you want to capture the accurate reflection of the discussion about patient safety. And as we all know in our world, if it wasn't documented, it didn't occur. So we're great documenters, we're great researchers, so rely on that. The other thing is reporting on patient safety and workforce events and initiatives, which I think is really important. And I'll talk a little bit about our HRO journey at Parkland, such as safety outcomes, improvement in work, risk assessments, event cause analysis, which is a keyword in a slide that I want to point out, which is helpful. And then infection outbreak, all of those things we're probably already collecting, but now we want to make sure we're documenting it, and also documenting at least 20% of the regular board meeting agenda for discussion time in regards to patient safety. The C-suite, and don't panic at this one, but the C-suite and individuals on the governing board are notified within 3 business days of any confirmed, there's the key word, serious safety events resulting in significant morbidity, mortality, or other harm. So what I did is I worked with I don't manage the board, I do attend. So I worked with the person that runs the meeting. We went through all this, and it was very nice to see that probably at Parkland, a lot of our quality is maybe 40 to 60% of the discussion. We have a quality board that meets just before our big board, and all those people sit on that, and then they go into their what we call the board of manager big board session. So we did confirm that was on there. And then I talked to my quality director and my QSO, quality safety officer. It's important to have those relationships. And the key word here was confirmed serious event. So for example, you could say that there was a fall, the outcome unfortunately was a death, but it was the seizure caused the fall. So there has to be analysis really on what occurred, and the confirmed serious safety event, I think, is the important part, along with the three business days as well.
Okay, moving right along to the second domain, strategic planning and organization policy. Policies and procedures are critical. Most hospitals have some form of policies and procedures that focus on quality, reducing risk, etc. But as I have found, and our other panelists have found, is that sometimes what's written on paper and what is actually achieved are two different things. Sometimes these policies collect dust. No one is really familiar with the policies. Quite honestly, I would say to all the registrants here, have you even seen a quality policy within your organization or the QAPI plan? What impact does it have on you and your responsibilities? Okay. And what is the ultimate goal in terms of preventing harm? Now, it's never going to be zero. Okay. But what we're seeing, and this is kind of from the first domain, we're seeing boards creating quality committees, credentialing committees. We're seeing board members sitting on medical staff committees that deal with quality and peer review so that they become more educated in understanding how do they carry out their responsibilities, their fiduciary obligations as board members, not just generally to maintain the financial health, but now in compliance with these metrics, with these domains that are really critical in terms of moving that needle to improve patient care. As everyone knows, the government and the payers are not paying providers based on volume. They're paying them based on quality, meeting quality metrics, quality standards. And if you don't meet that standard, you either get penalized or you get reimbursed less. So we can go to the next slide. And again, this is again part of the policy. What's the curriculum? What's the training? There's a lot of training that is expected at all levels, okay? And MSPs, certainly physicians and physician leaders, are critical to understanding how do all the pieces fit? What is the role that they play? How proactive can and should they be? And the more education, the more background that MSPs and physicians have, the more they bring to the table. You have a lot of critical insight. You're in the belly of the beast, so to speak. And part of that guidance too, you'll see a reference to candor. We'll talk a little bit more about candor with domain 4 and domain 5. But again, these are various tools in which to more proactively conduct those reviews, to conduct RCAs and other kinds of analyses that you do within the organization. So it's looking at what you have and what needs to be upgraded, what needs to be modified, what needs to be tracked. So Maggie?
Great. Thank you, Michael. So on here, the use of written policies and protocols. That's kind of our domain as MSPs that demonstrate patient safety as a priority. And referring back to Michael's comment is that in my department, we actually go through these policies. We have a matrix throughout the year. We don't review them all at once, but we review all the policies that not only medical staff, but also our medical staff is involved in. So we can at least see if there's any changes needed or not. And we want to keep on top of that. So one of the things is implementing written policies and protocols to cultivate a just culture. As I mentioned earlier, is Parkland is on their HRO journey. So a lot of this is already implemented and continuing to be improved. The slide I said earlier about the 3 days, we're actually looking at an improvement out of our safety system, which we'll talk about a little bit, in regards to triggering an automatic email to our board members as well as our C-suite to let them know when these things occur. So, and after the analysis. So we're looking at ways that we can maybe improve upon the 3 days, which would be great. Also to the just culture, we manage our peer review through just culture. All of our employees are managed through just culture. We have actually a one-page PowerPoint of the flow, so decision-making for managers and leaders is much easier. And also too, it was a learning experience for me as a leader, how to work my way through some frustrating situations and not having a finger pointing, but we can look at how we can improve in the process. And then we require implementation of patient safety curriculum competencies. So since my office manages all the physicians and our advanced practice folks, is we do track annually when they have their the training in regards to safety. And we provide that then to quality to say who's compliant, who's not compliant. We follow up with our chief. So we have 100% involvement and completion, and that is reported out to the board. Those are the kind of things we want to be really transparent about at Parkland. And we do regular assessments, death by meeting, death by survey, all of these things. Our physicians go, not yet another thing. So what we did is we went through and looked at what else are we having them do that's not really required. Can we retire those because this is now the priority? So we're looking at many different things. Like I said, build the relationships with your quality department. If you don't do peer review, build your relationships with that, and also your human resources department, because you want to align with what they may be doing for their employees as well. Next slide.
So domain 3, culture of safety, learning, health system. There are so many policies and procedures. It's difficult to be aware of all of them. Okay. And to emphasize what Maggie said on just culture, and we'll talk a little bit about it too on domain 4, is so critical. It's getting away from the blame game, right? It's recognizing that people make mistakes and, mostly inadvertent, some judgment issues, whatever. But be it physicians, be it nurses, be it any other healthcare personnel, the goal is fine. We have a policy, we have a procedure, we have standards. What are those standards? How are they being audited? How are they being monitored? And when there's a deviation, you sit down early on and try to fix it. You try to address it. A true HRO organization, and there are 5 principles, if we can go to the next slide. There's another good resource in the lower left-hand corner. Get rid of my spam call. But high reliability practices. Most organizations know what these HROs are, what the key principles are, but they include sensitivity to operations, reluctance to simplify, meaning, these issues are complex. They're not simple. Preoccupation with failure. Most of the issues that are identified within an organization are near misses, meaning there was an injury that resulted to the patient. That's not a success. That near miss can be the next event if it's not addressed, it's not evaluated, so as to prevent those near misses or those adverse outcomes in the future. Then the organization is failing. And relying on the expertise within an organization, not to think, well, I know it all, or a board member knows it all because they're a bank president or whatever their senior position might be. You have all this expertise, MSPs, physicians, physician leaders. This is such a multidisciplinary expectation and obligation in order for the organization to really succeed, develop that culture of safety in a confidential, protected environment, which we'll talk about in the next domain. And that way, when people know, hey, if I make a mistake, there's support there for helping me getting back on track, you're going to have a much better environment in which to, again, move that needle to improve patient care and reduce patient risk.
Well, we'll talk a little bit about integrating the suite of evidence-based practice and protocols. Culture is number one. And so what can occur in this training is, we don't want it to make it feel like the flavor of the month. What we want to do is have people understand those 5 domains and then relate it back to what they're doing. So a tier and escalating safety huddles. I'll tell you, my morning starts with an executive safety huddle with all major departments across the hospital. So ED, medicine, surgery, environment of care, IT, safety, and also supply chain. We all report out in the HRO method. Were there any operational issues in the last 24 hours, the next 24 hours? The other thing is, as well, is we report out any behavioral events or workplace violence. When we started to do that, it was an eye-opener. And, I had to give a lot of credit to our nurses and clinical folks in the hospital and what they had to go through. But we put together a plan. We have programs called Sparks. So if an employee is involved in a workplace violence is that we have resources for them. And we reach out immediately and we report out that those were followed. Hospital leaders participate in a monthly rounding for safety. So we do that the first Friday of every month. We are all assigned a different unit or area, and we go in and we talk about HRO. We talk about the challenges that they have, and we bring that back to our C-suite so they can identify, the areas they really need to go and do rounding at least quarterly and how they address that. So that's really important. Right after that meeting, I have a meeting with my immediate leadership team, and we meet and we talk the same way, use the same language operationally, no issues in the next 24 hours. We report out if there are issues prior. That's great communication because we find out somebody else on the team will go, hey, we're looking at that. We have this, let's collaborate, even in my own department. So it's been really important to connect and have these roundings. At first, people rolled their eyes and groaned, and we start with a safety story. We assign safety stories. We tell people to put a safety story in their pocket. So it's really important to have these huddles because it starts to open up what you need to do to integrate what you're doing as evidence-based practices and protocols. Data infrastructure to measure the safety based on patient safety evidence. Data collection. These data are shared with the C-suite. My quality department has tons of data. And a lot of times I'm like, I want to see some of that data because in our space, when we go through FPPE and OPP and reappointment, some of that data might be very important to look at so the chief gets a better idea of when they're reviewing practitioners' files as well.
Okay, domain 4, two to go, accountability and transparency. Let's go to the next slide because that's where I think where the rubber hits the road again. As many of you may know, I've worked a lot in the area of peer review and peer review privileges, as well as the Patient Safety Act, working with patient safety organizations, healthcare systems around the country, the risk and quality and in-house outside counsel. The Patient Safety Act, by the way, all of you are probably familiar with your state peer review statute, which provides privilege protections over discussions, minutes, other documentation. When there's an adverse event, you have an incident report, it kind of gets reviewed, escalated, actions are taken. But the Patient Safety Act, in which is probably 70 to 80% of hospitals, health systems are in a PSO or form their PSO, provides much greater protection than does any state peer review statute. And my guess is that a number of you that are listening in don't even know if your organization is in a patient safety organization. Your very first to-do, or among your to-do list that you'll see at the end, is go back and find out. Because if you're in a PSO, you have policies and procedures relating to what you treat as privileged. How does that information get collected? How does it get communicated? How does it get used within the organization to improve patient care and reduce risk? And MSPs are the holder of confidential information. So if you don't even know what your facility or health system is keeping privileged, you're missing the boat and maybe misusing inadvertently information and not keeping it as protected or putting it in the right file as you should be. So in addition to finding out if you're in a PSO, you need to ask for the policies that affect their participation in the PSO and what's being treated as privileged is information everyone that's listening needs to understand. How is it being used? How is it being kept confidential? More importantly, how is it being used to improve patient care? Hence, this is one of the key domain requirements, is to be participating in a patient safety organization. And not just participating, but making full use of the expanded protections that are afforded under the Patient Safety Act. By the way, if any of you are interested in getting access to a PowerPoint that we have that talks about the fundamental terms under the Patient Safety Act, the importance of policies, gives an example policy. It's some Q&As as to issues that come up about use and disclosure of patient safety work product, there's a QR code at the end that you can link to, and we'd be happy to send that to you. So moving right along to Maggie.
You have one more.
Candor. So Candor, some of you may be familiar with Candor. Essentially is a policy, and ARC, by the way, has an excellent toolkit that you should look at. Many hospitals have a Candor or similar policy. It's a recognition that when there is an adverse event that results in patient harm, that the hospital be accountable and transparent to the patient and to the family. What happened? Why did it happen? What are you doing to address the issue to try to prevent it from happening again? Keeping in touch with the family, because sometimes it takes a while for that RCA to be conducted, and you finally understand the cause and you understand what you're doing on your action plan to mitigate against future errors that occurred here. And so Joint Commission strongly supports Candor, as do the other accrediting bodies. And by the way, there are ways in which those communications can be kept privileged and confidential. You really just disclose the facts. But this, again, becomes an important tool and an important expectation in addition to participating in a PSO. Next.
Okay, so as we talk about the written policies and protocols to demonstrate that we are making patient safety a priority, is that we have a confidential safety reporting system. We just converted to a new one, so there is a little bump along the way, but it is well used. I will tell you, because I also oversee peer review, so I see the volume that comes in. We discuss the reporting system at an executive safety committee that I attend, because I'm always, as an MSP, listening for those little hints of what I need to go back to my office and check out. But, that allows the staff to feel safe in reporting safety events, near misses, precursor events, unsafe conditions, other concerns. But the other thing that we also do, and maybe in not the reporting system, but when we report out in our executive huddle in the morning, we also report on good catches. And so good catches are also important, because that lifts people's spirits a little bit, that we're not, looking for things necessarily that are always going wrong. We want to let them know, hey, things do go wrong. We need to address them. But here are some good catches that we have. If we do have an event, right away it's categorized. So when they're explaining it, we have a quality meeting from 3 to 5 on one Wednesday a month. All of this is tracked and recorded. I may hear about a case 4 or 5 times as it goes through the process. Patient safety metrics are tracked and reported to all clinical and non-clinical staff and public. So a lot of it we have displayed. We have quality boards that are in the hallways for each unit. We also have displays that talks about our quality and initiatives that we are doing. And also too is that we report all of these measures to our governing board at least quarterly. And it's a requirement, to be able to do that. And the thing is, our board is very, very involved and engaged, which is something, to me, makes my heart sing, since I can actually attend the board meetings. They're very engaged. They're always concerned about patient safety. They always ask really good questions. Thankfully, we have answers for them. So it's really important to make sure that these are tracked, reported, you have a safety system. And if you're not involved in this area, again, relationships, reach out to your quality team and patient safety team, ask them about it. Make sure you as an MSP are also going down your checklist to make sure that if you're not doing it, you're aware of it and you can speak to it. Next slide.
And to pick up what Maggie said, everything that she described in her slide, her discussion there, all of that, those minutes, those discussions, those huddles, those email communications, all of that can, again, be kept privileged and confidential under the Patient Safety Act, and possibly under your state law as well. And that's important. to be able to feel comfortable and transparent with each other in a spirit of just culture, that when there is an adverse event, and the goal is, okay, how did this happen? What can we do? What's the analysis? How do we move ahead and improve going forward? All of that can and should be conducted within a protected space, okay? And when people feel supported, people know that they're achieving some good outcomes because of those discussions, then we're fulfilling obligations, that are owed to patients and to the community, as well as to deliver equitable care, especially in Chicago and the West Side and the South Side. The care that happens there isn't quite the same as it can happen in an academic facility, despite best efforts. And that's part of the goal of the domains as well. When we talk about domain 5, patient and family engagement, again, as part of transparency, is part of just culture, as part of being transparent to families and caregivers. If we go to the next slide, one of the attestation and expectations is the creation of a patient and family advisory council. It's multidisciplinary, cuts across age, race, ethnicity, looking to who is your community and patient population. How are you getting them involved? How do you even know what the community wants, what the community needs, unless you have active engagement with the community, okay? And so this is an expectation. And at one point, it'll be a requirement that you have a similar council, committee, whatever you want to call it. And that type of communication back and forth really helps the hospital to zone in on what are the real needs of this community, especially when we talk about mental health as well, which is a big gap, as I think we all know, in terms of coverage, in terms of services that are being provided and being paid for. So again, this is as important as any of the other domains, and an expectation and ultimately a requirement for hospitals and health systems to adopt.
So in regards to that, one of the things that, I'll say is I'm very proud to work at Parkland. It's a county hospital, if you do not know that. So we've always had community members as part of our board. And, part of that is they're the ones that are asking a lot of the good questions. But including the representation on the board meetings is we provide consultation on safety setting goals and metrics to the board. They can participate in safety improvement initiatives. They have rounded in our hospital. They have gone on their own on the weekend. They get a badge and they'll go around and they'll talk to the staff, and they'll talk to patients, which is really important. And patient have comprehensive access. So I'm going to talk a little bit about what Parkland has done, and I'm sure other organizations have done, is we go through equity and also care provided by zip code. So Dallas is a very diverse area, and our hospital, Parkland, is a county hospital. We're about 94% Medi-Medi with only 6% commercial. So it's really important that we know about our community and how we can serve and culturally as well as linguistically. One of the data points that was provided to the board when I sat in was rather shocking. One of our zip codes, their life expectancy in that zip code is 28 years less than another zip code in the Dallas area. So, but that helps us pinpoint, where do we need to put our clinics? Where do we need to expand our clinics or services that we're doing? Do we have interpreters available? There's a lot of things that, Parkland's very data driven, which I'm a data geek. And so it's really good to see that they're using that data. They're not just collecting that data. So it's really important to have your board know that is going on. Share those data points with them. Concern was there about that one zip code, but within, I think, a year or two, we had opened a rather large clinic in that area. So hopefully we can help the health and longevity of those folks that live in that zip code.
So I'm going to give Maggie a chance to catch her breath. and make a pitch to the physicians in the crowd about how important your MSPs are to not only your practice and how you take care of patients in the hospital, but
Mhm.
going forward, how they're going to be really integral in enacting this PSSM at your facility and how you need to interact with them. They do the heavy lifting here, and Maggie's going to describe some of the things that are going to be important that are MSP specific.
Okay, so I love this image of the Swiss Army knife. HRO principles allow that Swiss Army knife to have full use, that's for sure. So MSPs were relied upon to ensure the compliance with PSSM, and I can feel my MSPs right now going, "What? Just another thing." But if you study it and you create the relationships with your quality, patient risk, patient experience folks, is that you can work with them to ensure the compliance, make sure the policies address this. I go back, right away, I asked our board members going to be signing those attestations at our meeting next week, our board meeting. They said, absolutely. So, it's those kind of things that we can also help other people recognize what we do. You have to put yourself out there. You have to ask those questions. So I think, here it is, closer integration with those other teams and your credential committee. Information gathering. Every meeting we attach an article on various things. So our physicians can read that. At first they didn't, but now they're reading everything that we send along. Holding people accountable, the C-suite, physician leaders. We do a lot of the communications. We do a lot of interaction with the physician leaders and also all of our committees. We make sure that we have the minutes reflect that the number of meetings is very important, subject to audit, the 20% dedicated time to each board meeting. Even if you don't attend, ask. It's as simple as asking and making sure you have that integration. We want to be the center of communications. As we said, we're always the gatekeeper of patient safety, but we also need to be the gateway to safe patient care. And then, I'm sure a lot of you are probably going to go, we love research, we love references. I highly encourage all of the references that were provided during this. Go to them, start to read. Your eyes will be wide open, but don't be fearful. So get organized now. Get a checklist, check off all the things we've talked about. Make sure that there is a flow of crucial information, timelines to help with documentation. That's why we have a matrix on my governance team, what they need to be looking at each month. There may be no changes, but at least we have eyes on and we document we have eyes on. Make use of technology when it makes sense. AI scribing for meeting minutes. We're just getting into that with Copilot. Of course, you go and you have to adjust it. You just don't let it go forward. There's somebody has to review that work, and the MSP is the one to be able to do that and make sure it's on point. You want to make sure also that you have a robust team to do that. And I'm fully sensitive to the single MSP that might be sitting in an office right now and manages all of this for their organization. But if you start now, you plan now, you work and collaborate, build those relationships, I think you can definitely build some confidence in knowing that you have addressed all of these issues.
Thank you.
Mm-hmm.
So I'm going to talk a little bit about what I think is sort of the missing secret sauce in making this whole process work. And I think it's sort of a forgotten resource for a number of reasons. Physicians no longer really feel terribly engaged with a lot of the things that they really need to be involved with. You take a big step back and think about how hospitals are organized from a management standpoint, from an organizational standpoint. There's a trifurcated governance. There's a governing body, the hospital board, the hospital administration, and the medical staff is a crucial component of that. We tend to think about the governing body, the hospital board, and the administration working more hand in glove as far as financial viability is concerned, making sure operations are smooth, meeting the community needs. But when the rubber meets the road, when there are competing priorities, it's not uncommon that patient safety can get lost a little bit in the shuffle. And that's part of the reason that medical staffs are crucially important. Well, with this new PSSM, there's got to be some more involvement between the governing body and the medical staff. You know, CMS has not quite put a target on the hospital boards, but they've basically said you are front and center in taking responsibility for the safety of patient care delivery in your facility. You are the ones that are going to attest to it, not the CEO, not the chief nursing officer, not the chief medical officer, not the chief of staff. It's the board members. Well, how are they going to get that information? They can only get it from the people who are clearly designated as being responsible for quality of medical care. The CMS conditions of participation very clearly state the organized medical staff is responsible for the quality of medical care provided to patients by the hospital. Again, it's up to us as physicians to grab hold of that and then be heavily involved with it. Why are physician leaders so important? I mean, they have a personal and a very professional interest in quality care. In addition to that regulatory requirement, they want the best for their patients. They have community ties. They're there for the long haul. They didn't move to Lubbock, Texas, to work for 2 years and move somewhere else. They moved to Lubbock, Texas because that's where they grew up. That's where they want to practice. And that's replicated across the country. So these folks have deep community ties. They're your best translators of clinical information for your board members. And they're also the most effective lobbyists for whatever necessary changes need to be. It's not pitting physician staff against the administration. It's basically being an advocate for patient care in a manner that the administration may not completely understand or necessarily always agree with. Because they have deep community ties, because they're there longer term, with the average C-suite member lasting about 3 to 5 years in the United States, they have the deep institutional knowledge. Why are we here? How did we get here? What's the history of this problem that we've had with getting patients from the emergency department to the ICU in a timely fashion? What's the whole story? What's the whole history? So your physician leaders are really crucially important in helping your board members truly understand what's going on from a clinical perspective. So what do? Well, I think it's really important that the more board member and physician leader interactions occur, the better. So you need to encourage that. You need to establish some dedicated time for them to meet and greet. Establish some rapport. Some of that just simply needs to be casual events.
Yeah.
You need to make sure that physician leaders participate in board retreat activities. And most importantly, you need to expand physician membership on hospital boards. They need a seat at the table. I've been very fortunate to have traveled across the country over the past few years working for Hardenbergh and interacting with medical staffs of a variety of different stripes. And it's not uncommon that they don't feel like they have a relationship with the board. It's not uncommon that they aren't reporting important data to the board. That has to change so that the patient's safety structural measure can be met and that we can improve safety. You need specific physician-delivered quality metric discussions at all board meetings. So I grew up in Texas. My wife's family's from this little town in Mount Pleasant, and they had a store there called Everybody's Furniture. And I view a lot of hospitals acting like Everybody's Furniture. It's a place where if you saw a nice sofa, 2 weeks later it was gone, you'd know whose house it was going to be in pretty quickly. There are other hospitals that are a little bit like IKEA or Pottery Barn. They're larger. The relationships have to be the same across the board. And I would say that physician-leader relationship with hospital board members is a lot easier at Everybody's Furniture and maybe a lot harder at IKEA. But the resources available are different as well. So the struggles that each individual facility are going to face are going to be different. But making sure that your physician leaders feel comfortable, whether they're at a small facility or a large facility, interacting with your board members is really crucial. So how do you do that? There's a process that some hospitals have undertaken called suits to scrubs with the administrative team. But oftentimes they do that by themselves. What's really important that they need to start grabbing docs to go along with them. They get out of their suit, they walk around the hospital, they go to different units, they talk to the staff. They may spend an afternoon in the emergency department. They may spend some time in the pre-op area, actually interacting with folks. And then having the chance to converse with physicians who work in those units is also very important. That same process can happen with your board members. You know, it's kind of facetious to say, but take your board member to work day is not a bad idea. The idea of psychological safety has to start at the top. And your staff members will never feel that psychological safety when somebody in a suit who they've seen once a year walks in for 3 minutes and says hello, in comparison to that person who they met who spent the day with them, trying to understand what they're struggling with. Are you seeing safety issues in your unit? Are there things that we can address as board members? Are there things that we can jointly address as board members, physician leaders, and administrative staff to make things better? We've talked a lot about HRO today. I am a huge advocate for HRO processes. I think that every hospital can benefit drastically from having an HRO program, but it does not work at all unless everybody's involved. The best HRO teachers are the surgeons in your hospital because they're oftentimes the most feared people. And they are the only ones that can make those folks feel that they have a sense of psychological safety if they interact with them and lead HRO discussions. The same thing can be said for your board members. If you're in an HRO program, your board members should be going through that same HRO training, and they should also help participate in teaching those classes. So Mark has a couple of takeaways for us to talk about. Kind of what is your to-do list?
Actually, it's better if I actually get hurt, I guess. So we have a strong belief at Hardenbergh that you need to walk the talk and that you should really be committed to the action side of all this. And so we wanted to finish with just some to-dos that what are some practical things to get started. And most of this has been alluded to with the various presentations, but start talking. Start talking to each other. Start talking to the administrative leaders, to the physicians, and to your quality patient safety teams, and then engage with the hospital board. And as Brock pointed out, this is really a culture change. And to do the culture change, everyone has to be involved, and there has to be a long-term commitment to see it get carried out. Make a plan and a timeline. If you really have the commitment to this culture change, then a plan will work. But a plan has to have a timeline. In other words, it can't be open-ended. Identify your weaknesses and bolster your strengths. It really is a practical way that you can get things done in a positive way, and lean on your available resources. What do you have already that you can work with as you develop the new resources necessary to carry this out? So a lot of those are common sense and maybe just flies in the face of yeah, sure, of course, do that. But you really do have to think it out in a proactive manner. With that, I'm going to thank our panelists for a great presentation. I hope everyone appreciates that this was probably a 6-hour presentation that got squashed into an hour, and we could have definitely gone on. But we're going to switch over to the question and answer period, and I will start that and throw it out. And I think I'll start, Brock, with you, but everyone should join in. Specific question came, does the mandates apply to ambulatory surgery centers? I think the more general question is, who does this apply to? Who doesn't it apply to? So who needs to take action on these things?
Well, I think that's a great question. The simple answer to ambulatory surgery centers is no, but I would throw in a big but, and the reason is hospitals obviously are in the crosshairs for this PSSM, but they're not the only place where quality of care is important. And I would be surprised if after this PSSM starts to be enacted that they don't turn their attention to ambulatory surgery centers, particularly because the types of cases that are being done there are becoming significantly more complex with sicker patients, and they're going to have more complications as time progresses. That's just a natural fact of evolving healthcare. So understanding the PSSM, actually understanding things that you can do to prepare would be very, very helpful, not only for meeting the measure if it ever comes down the pike to your facility, but also because it's good for patient care. As far as who it applies to, functionally, everybody that runs a significant hospital facility in the United States. There are a couple of small exceptions, but by and large, if you are working in a hospital, you're under the PSSM guidance.
And I would add, I mean, now that hospitals are part of large health systems, they have surgery centers, they have clinics, they have physician groups, they have pharmacies. There's this spread out clinically integrated network. And if you start walling off, other component parts of your system and just focus on the hospital, I think you're selling yourself short. And as a board member, they need to be responsible for the entire system, all of the patients that are being treated, how you're reaching out to the community. And so, yes, technically the attestation, the other domains may only apply to hospitals, but if that's your sole focus, I think you're actually doing a disservice, to your community, as opposed to looking at the entire system as a whole, as you're engaging in these proactive efforts.
So, Michael, I think you've raised a really interesting point, which is one way to approach this is just to tick the box off, right, and meet the absolute requirement. But the other approach is how do we encompass this in our everyday operations, so to speak? So anyone want to talk to that a little bit? You have talked to it somewhat, but I think it's worth reemphasizing.
Well, look at it. For example, I just had a call today with a client. They have 10 hospitals. And this is in the context of their participation in the PSO, the development of the PSCS policies. They have a very extensive quality plan or QAPI plan. And for each of their hospitals, they have a plan for their surgery centers, their clinics, their physician groups, all of their affiliated entities. Okay. It's all part of an overall plan. And it all has to be integrated and understood. And it's not easy, especially in a large system, but even in a smaller hospital that has other clinics and other affiliated entities. So, and all of that information, especially when you're trying to keep patients like within your system. You don't want them transferred out to another hospital, another clinic. You want to keep them contained. You want them in the system. You want to improve that continuum of care and be able to track those patients, track those outcomes, track those errors, use that information, use that data to the benefit of the community and the entire system, and obviously the patients. So, to me, it's like you really can't start walling off entities within the enterprise because, again, I think you're not going to achieve the expected outcomes that the industry is demanding, the payers are demanding. Okay, that's just the simple reality.
I think that's a great point, Michael. And I think the other piece is if you're going to approach this as a checkbox issue, then you're not going to move the needle. And I think that's why we have this new guidance. We had a lot of safety structures in place, and most of the time they were being met by checking the box. If you listen to what Maggie had to say about everything that they've undertaken at Parkland to start meeting this PSSM, everyone is involved. She's got very engaged board members. She's got very engaged medical staff leaders. She's got an entire system that they're still tweaking, not just to check boxes, but really to meet the spirit of what this PSSM is asking of us. And what's asking of us is we need to improve quality of care. We need to improve patient safety, and we haven't done it so far. So if we take a checkbox mentality into this, we aren't going to make any improvement either.
Yeah, and I think that fits with the general principles of changing organizational culture too. It's just not going to happen. We had a number of questions on clarification about financial penalties and public reporting. I just wondered if any one of you would like to talk to the specifics of that. There's questions about when does that really come into effect, et cetera.
Brock, you had a slide on that, didn't you?
Yeah. So basically, the attestations start now. Maggie's having actually her board start to do that currently. So that's going to be starting to be publicly reported. There's a CMS website that I don't know the name of, but it's going to be actually part of the standard reporting for hospital safety measures that you've got board members that are attesting that they're meeting 1, 2, 3, 4, all of the PSSM domains. The financial penalty piece is not going to start until 2027. How that takes shape has yet to be determined. How they're going to do audits and monitoring of this has not been completely spelled out. So I think the answer for facilities is document everything that you're doing, make sure that your structures are in place, that you're actually meeting these measures, and it's not, again, a checkbox by your board member saying, oh yeah, I think we're doing that. But making sure that you have the policies in a book and that you've got all of your minutes that are available for review, so that whenever CMS decides this is how we're going to look at things, you've already got that data at your fingertips. How much of a penalty is going to be imposed, I think, has yet to be determined as well. But I don't think it's going to be small this time around.
Another comment I would make is your policies, your procedures become your standards of care. Okay. Meaning you can't just adopt a policy, you can't just adopt a procedure and not follow it. Okay. Not following policies and procedures can lead to regulatory implications, liability implications, reimbursement implications. And so you have to give serious thought in not just evaluating what policies you have now, but how you're going to review and amend and update those policies. And importantly, how those get communicated within the organization. As has been pointed out, this is a multidisciplinary initiative. It involves everyone across the board. Everyone has a responsibility. Everyone has a duty. But they have to be kept apprised as, okay, what are those responsibilities? What are the policies? And this goes into transparency, goes into training, it goes into updating. And deviations have implications. And so you need to be mindful that it's just not paying lip service and checkboxing that, oh yeah, we met this, we met that. It's a standard. It's a regulatory, a reimbursement and a legal standard that you have to follow and comply with.
Yeah, I would just suggest that in this day and age of social media, that the financial implications from public reporting may be as great or greater than any financial penalties that may come down the line. So I don't think there's any benefit in trying to delay until such time as they get to the financial penalties, because you may already be in the throes of suffering the downside sling, so to speak. Maggie, I think we'll start with you on this one. There was a question about training physicians and AHPs in this area. Any thoughts on best ways to get that started?
Well, the actual training materials and everything is managed by our quality department. What we do is help facilitate the connection to those training documents, and then we track completion of it, so we can have a report that we can send to our medical executive committee or the board. So, it's okay to be the facilitator, because then that draws you into the areas to say, what are we doing? Don't just say we can send this out via link to our physicians. We take a look at what we are sending, so we get educated along the way. So that's how we manage it. At this time, MVP, minimal viable product. I'm sure that as we grow and learn things, that we'll be able to expand on that.
Great. Any other thoughts from anyone else?
I think, again, going back to HRO training where everybody has to be trained, it's not a one-time, one and done type of a thing. This is an ongoing effort. And so making sure that your physicians, your allied health professionals have the opportunity to be in a room with people to have a real discussion, and not just a webinar type of a presentation where they can be doing 6 other things, but a real understanding of, this is our facility, these are our policies, as Michael said, these are our standards that we have to meet. Let's make sure that we're all on the same page. And it becomes something that is self-sustaining, because it generates a lot of discussion. And oftentimes it generates, I think, changes in thinking about opportunities for improving safety. So I would take a page from the HRO training process and implement it across the board.
So we do that. We do have sessions. We started off with executive folks going to training, and then universal. This is universal. And then for our practitioners as well. We wanted to make it impactful to each one of those, because it means different things to different people. What is the important things they need to do? I just happened to look up, and this was sitting in my pile that needs to be gone through, but it's, right there at my fingertips. So we do that. The other training is supplementing the in-person.
And Michael, I would presume that all those comments would equally apply to candor training.
No, I mean, absolutely. And policy training, again, I harp on patient safety organizations, but
Yeah.
they're so intertwined with what the expectations are under the domains and the type of education. And I would say too, what becomes critical are the involvement of physician leaders, department chairs, those medical staff leaders, those champions who, are very influential within an organization, and whether they're sitting on a board of directors or not. And yeah, you can incentivize employee physicians or department chairs by, adding training and understanding policies to their job descriptions. But, that's only the handful of people. They are the ones that have to lead. They are so critical, the medical staff as a whole, and the interaction between the medical staff, as Brock indicated, and the board, and vice versa, that finding those individuals who are really committed, not only because it's a requirement, but it's a passion, it's their goal, it's why they're on the board, why they're a medical staff leader, and sometimes you need some incentives to move them along, but whatever it takes, I think becomes obviously very critical to the success, and again, improving patient care, reducing risk.
Yeah. I think, there's been a lot of discussion over the past several years about physician burnout and physician disengagement. That's a completely different topic, but there are a lot of reasons for that. And one of them, I think, is that physician leaders oftentimes feel that they're being basically stuck in a position that nobody else wants. You've got to do this, you've got to sign this piece of paper, et cetera. You got to go to this meeting. I think this is an opportunity again for a culture shift, and that culture shift has to involve your medical staff. It has to involve your physician leaders taking ownership and taking pride in quality patient care, not just of their own patients, but as this for the hospital as a whole, for the system as a whole, saying, I want to make a difference. And I think that can significantly drive, I would hope, a resurgence in physician engagement.
Okay. Next question is, I think, mostly for Michael, and I don't want to trigger the 3-hour discussion that I know it could, but we had a couple of people ask about the trends in case law in the last 5 years in terms of either enhancing or clarifying the protections for PSOs.
Excellent question. The short answer is we're getting a lot of good case law outcome. We've now, after 16 years, been in a position to better educate the courts about the Patient Safety Act, getting good court decisions which have upheld the protections under the Patient Safety Act, rejecting arguments that plaintiffs' attorneys and judges have relied on because, as a general rule, the courts don't like privileges. So we've had some very good successes. We're probably, and I put on programs to talk about some of these cases, which we'll probably do in the future, and doing a lot of in-service educational programs at hospitals, health systems. I'm doing some coming up in New York, New Mexico, other jurisdictions. And so I'm encouraged that we're finally, breaking through and impressing upon the courts that, hey, this is a good law. It's been passed to promote patient safety, improve patient care, and we're finding successes. So that's the good news. Yeah.
Great. Thank you. Maggie, I think we'll let you have a first crack at this one.
Okay.
What successful methods have you experienced or utilized to help promote MSP participation in PI projects and non-medical staff committee meetings?
One of the things I did is ask questions. So once you ask questions, you're kind of voluntold. So you have to get out of your office or off your screen. FaceTime is so important for the MSP because nobody realizes the depth and breadth of what we provide for the hospital. So you need to insert yourself. You need to ask questions, and volunteer. Say, hey, when you guys are going through this, I'll scribe it. I mean, so there's many ways that you can insert yourself, and you have to insert yourself because, like I said, people don't understand the depth and breadth of what we do, may not even recognize that there's this role. in hospitals. So you need to get out of your comfort zone. You need to insert yourself. That's the one thing I would say to MSP. I ask a lot of questions of different departments, and then they ask me, would you like to be a part of this? And I said, I would like to be a part of a committee to see what the impact is for my medical staff. If I don't feel any, then you can just excuse me from future meetings.
Great. Anyone else have any other thoughts on that? Think
I
that
always make the comment that they need to double their salary and double their budget because they're so valuable, they're underappreciated. But to Maggie's point, they have so much to bring to the table, but no one's going to realize that unless they come forward and try to take that initiative. And whether that means a promotion, whether it means more salary, whether it means more staff, once they understand everything that the MSPs are grappling with and what they're trying to achieve, especially, the smaller hospitals and whatnot, but even in large hospitals, they don't know unless they make themselves known, the leaders within the organization. So, yeah, it's easy for us to stand here or sit here and say that, but having been on the board of NAMSS and working with a lot of the state facilities, state associations, there's so much talent there. There's so much to offer, but again, not a lot of time and not a lot of budget, so it's difficult.
I absolutely agree with you. And I've always found it interesting, and I'm pretty sure Michael and Brock have found the same thing about how scarce CFOs make themselves whenever we show up. It's like, get away from those guys. They're going to recommend more expenses. Here's a question. I think we'll start with Brock, and that'll be our last question, and we'll move on, which is what comprises a feedback loop? In other words, how do you carry that out under these under these processes?
Well, you can't really have a feedback loop unless everybody's willing to participate to a full extent. In other words, you can't have folks that fly in for one meeting, make a bunch of comments, and then don't participate again. So, feedback loop, to my definition, is everybody's at the table. You discuss a problem. You come up with proposed solutions. You got to go away. Everybody has to do their own research to figure out whether or not that's a viable solution or whether or not deeper problems exist. You come back, you rediscuss it, and then you have to implement it. And it's a little bit like an OODA loop in the military. Orient, observe, decide, and take an action. And if you don't then have that follow-up after action meeting, you don't get adequate evaluation of whether or not the action that you took was appropriate.
Okay, great. Well, with that, I'm going to wrap it up. Unfortunately, we've run out of time. We have some more questions, and I promise that we will get to those in our follow-up and get answers back out to everyone. Let me reiterate about our Senior Medical Staff Leader Forum that's coming up in April. We think it's going to be a great event, and you can see the people that are talking at it, and there's a great range of topics that I think will be of great interest. And hopefully, if you aren't a CMO type leader that could come to that, you'll know someone and pass the word on. Know that these webinars are available for CME credit, and you can go to the resource page on our website. And we have a number of other seminars that are listed here that you can go to as well. And finally, here's our contact information and a QR code. And this QR code is for getting a 15-minute consultation for all those who had questions about resources that could be applied or follow-up actions or any other follow-up questions. If you sign in with this QR code, then they'll set up a 15-minute meeting with a senior consultant, and you'll be able to get all that handled and answered.
And it'd also be a way if you wanted to get that PSO, Patient Safety Act PowerPoint presentation that I referenced during my discussion on Domain 4, that would be another way to communicate, and that PowerPoint presentation can be sent to you.
Great. Any last comments from the panel? Thank you for an excellent presentation. And I think that'll conclude our webinar.
Thank you,
everyone.
Thanks, everybody.
Okay.